Hi everyone, good afternoon. My name is Jennifer Barrett. I'm coming to you from Wongal country, which is one of the mighty parts of the land of the Eora Nation. And I'd like to acknowledge all of the lands that you're all coming from today as well, and to pay my respects to elders of the land, and to acknowledge that this land and the lands that you're likely to be coming from have never been ceded. And with that, I will start the proceedings for today. I'm Professor Jennifer Barrett, Pro-Vice-Chancellor, Indigenous Academic and Director of the National Centre for Cultural Competence at the University of Sydney. Today you will hear the latest OzSAGE advice for people living with a disability, one of our most vulnerable populations. You'll also hear an update on Aboriginal and Torres Strait Islander health, and there will be time, as always, for questions at the end. Please raise your hand or place questions in the Zoom chat, and we will answer those in order. And always remember too, if you have any further media inquiries after today's conference, please direct those media inquiries through Amy Stevenson. Amy Stevenson is at the University of Sydney.com, AU. I'll forward all that detail in a moment again, so thank you for that. So today's conference will be recorded and made available on the OzSAGE website at www.ozsage.org. Thank you. Now, who is speaking today? We have three speakers. We have Professor Lisa Jackson-Pulver, who will provide an update on Aboriginal and Torres Strait Islander health. We have Professor Raina McIntyre, who will speak to current statistics and deaths at home, and Professor Anne Kavanagh, and she will present OzSAGE advice for people living with a disability, and is the chair of the Disability and Health, is chair of Disability and Health at the University of Melbourne in the Melbourne School of Population and Global Health. So there are three presenters today. We'll proceed with hearing from each of those, and then we'll have your questions at the end. Thank you for joining us. I'll throw over to Professor Jackson-Pulver now, who will give us an update on Aboriginal and Torres Strait Islander health. Thanks, Lisa.
Good afternoon, everybody, and thanks so much, Jennifer. I'd like to add my voice to the acknowledgement of country. My name is Lisa Jackson-Pulver. I'm a Professor of Public Health and an epidemiologist, and the Deputy Vice-Chancellor, one of the Deputy Vice-Chancellors at the University of Sydney. This advice has come from the working group of OzSAGE, the Aboriginal and Torres Strait Islander working group. I'm coming to you from Gadigal land in Sydney. As the COVID pandemic continues in Australia, we need to make absolutely certain that no one is left behind. To do this, it's the recommendation of the group, the Aboriginal and Torres Strait Islander OzSAGE working group, that more than 90% of Aboriginal and Torres Strait Islander people over the age of 12 need to be fully vaccinated. This advice has been given each week we've had this presser. It's not been achieved in New South Wales to date, and therefore the relaxation of restrictions poses real threats to Aboriginal and Torres Strait Islander people. Aboriginal health leaders from other states and territories continue to advocate for high rates of vaccinations, with John Patterson, for example, from the Aboriginal Medical Service in the Northern Territory recommending a 95% vaccination rate, and the National Community Controlled Health Organisation CEO, Pat Turner, recommending a 100% vaccination rate for all Aboriginal and Torres Strait Islander people. As stated in an article that was just published in Internal Medicine Journal, Aboriginal organisations have called on state and federal governments to delay any substantial easing of restrictions until full vaccination rates among Aboriginal and Torres Strait Islander populations over the age of 12 reach 90 to 95%. We fully support this. This is to ensure our survivorship, and this is to ensure that absolutely no one is left behind in this pandemic. Aboriginal and Torres Strait Islander people have been infected with COVID-19 at a rate of almost 2 to 3 times higher than those of non-Aboriginal Australians. Aboriginal and Torres Strait Islander people have experienced an incident rate that is almost twice that of non-Indigenous people throughout the Delta outbreak. That means around about 430 Aboriginal people have been infected versus 250 non-Aboriginal people per 100,000 people in the population. There are over 5,000 cases since the beginning of this pandemic. As of the 17th of October, that's just a few days ago, New South Wales had 4,694 of those cases in Aboriginal and Torres Strait Islander people. The ACT has over 120 and Victoria has around about 150 in this current outbreak. There have been over 500 hospitalisations, 50 of whom have landed in ICU, and there have been 10 deaths. And I'm sorry to report that we're expecting more in coming weeks. Most of those deaths have been in people who are younger, that is, under the age of 60. And 1% of COVID cases in the 40 to 60-year-old age group have died. This case fatality rate is approximately 3 times that of non-Indigenous populations. Vaccinations as of the 17th of October, there's been about 56% of the population aged 12 and over who have received at least 1 dose of the vaccine. 41% of the population 12 and over are fully vaccinated. These are vastly different from the vaccination rates aggregated across the rest of Australia. 41% over age 12 are vaccinated. So this is a number we need to be mindful of. This pandemic is exacerbating already existing social issues in remote communities. We're hearing stories of places like Brewarrina and Bourke in New South Wales where they've highlighted serious issues. Some are reporting that they feel as though the world has forgotten them during this pandemic. People feel as though COVID is actually crippling them. Some of the issues in communities are very real and happening. So, for example, there's significant anxiety because of the way COVID is spreading. There's increased interaction with community members between the police and the ADF, and many of them are being arrested and fined. But of course, there's a lot of people won't be able to pay those fines, so that will have consequences. Basic fresh food in many communities is really hard to get, and primarily going to those who can afford to pay higher prices. This has always been an issue for many in communities, but with COVID and quarantine and isolation, these are just being exacerbated. Connectivity is a real problem as well. Another example is in a place called Angonia. Angonia is not really helped with the provision of dongles into community to be able to access the internet. They don't have any satellite infrastructure that can help the Angola community. And when you've got children and young families being deprived of access to education and the ability to connect with family and with medical advice, it becomes incredibly difficult, and you can see where the inequities are abundantly obvious. There is an urgency to get Aboriginal and Torres Strait Islander people vaccinated. We have a younger age population with higher rates of underlying conditions that can impact the spread of this disease and the severity of the disease should people become positive with COVID. Expert analysis also suggests that the proportion of deaths in younger people aged 40 to 59 is about 3 times higher than that of non-Indigenous populations. In children aged 11 and under, the rates are almost double that of non-Indigenous Australians. About 80% of all Indigenous infections are in people aged 39 and under, with the largest single group being from children birth to age 9, followed closely by preteens and teenagers. So this is definitely one of those situations where COVID is spreading amongst the youngest, and the majority of them more vulnerable because they're not eligible for vaccination at this point. For Indigenous people in their 30s, 14% of those infected were admitted to hospital. For those in their 40s, 18% were hospitalised. We know COVID is a disease of the unvaccinated, so if it gets into regions and communities with lower vaccination rates, it will spread faster and further amongst our most vulnerable. We have the capacity as a nation to work together to ensure the safety and security of all of our citizens, but there is much more that needs to be done to better support the vaccination of Aboriginal and Torres Strait Islander people in their homes and in their communities. I repeat, to ensure survivorship, we need to ensure that absolutely no one is left behind. The good news is that thanks to the extensive efforts of Aboriginal community-controlled health organisations and efforts working with those organisations by the Commonwealth, State and Territory, the pace of the vaccine rollout for Aboriginal and Torres Strait Islander people in the ACT, New South Wales and Victoria have been moving at a pace. Vaccine uptake in other jurisdictions remains slower, with some Aboriginal communities in remote Australia reporting as low as 5% of their community members in the eligible age range, that is 12 and over, being vaccinated. So that means there are some communities in Australia today that are only 5% fully vaccinated. This is a real risk. The fact is that Aboriginal and Torres Strait Islander people continue to be vaccinated at a rate that is around about 20% lower than other Australians. With the lower vaccination rates and great impact from COVID, it's therefore very important that attention, resources and innovative approaches to supporting people in their communities get vaccinated, particularly to those services who are already doing the hard yards. It's time for our governments to continue listening to the medical experts, to our Aboriginal community-controlled health services, community members, and to those people working on the ground that are ensuring that Aboriginal and Torres Strait Islander people have all the things that they need to protect themselves further and each other from COVID. In order to access the needs of different communities and different regions, there is a requirement for information on service availability and impact. Despite the recommendations and ongoing call for accurate and appropriate data, there still remains a clear need to provide transparency, quality, as well as the availability of disaggregated data. The data that is broken down and displayed by population group and regions does not seem to be able to accord with what I have just shared with you. 80% is not 40%. There continues to be no public release of current denominator data used to derive Aboriginal and Torres Strait Islander vaccine proportions, and this needs to be addressed. These data are really important because it lets us know who needs what, where and when. As New South Wales marches on with relaxed restrictions and other jurisdictions work towards easing their restrictions, everyone needs to know that there are people being left behind. It's a responsibility of governments, of individuals, of all of us to support and protect those priority populations that need additional assistance to ensure equity within this nation during this time. We want to make sure that no one is left behind. Thank you.
Thank you, Lisa. I think it is important to reiterate that what we're talking about here is not leaving anyone behind. And we'll hear in a moment about another group that has been marginalised in some of this work. So we go now to Professor Raina McIntyre, who will provide us with an update on the statistics and deaths at home. Over to you, Raina. Thank you.
Thank you, Jennifer. And I'm speaking to you today from Ku-ring-gai land in the Eora Nation in the northern part of Sydney, and pay my respects to elders past and present and emerging leaders. Can I have the slides, please? So just a recap of the data for the last week, there's been 15,993 new community cases. Almost 50% of these are below the age of 30, and you can see the age distribution on this graph on the top right there. And you can see the single largest group is actually children, 0 to 19, which is what we would expect to see because vaccination rates are very high in older adults, and many children are not eligible yet for vaccination. So that's where we would expect to see more transmission, and I think this trend will continue. When you look at the, we haven't got the age breakdown of vaccination here, but people in the 20 to 29 age group are also less vaccinated than older adults. So what we're seeing in terms of the incidence of cases very much reflects the level of vaccination. 30% of the cases were 0 to 19 years. 68% of those 16 and over are fully vaccinated across Australia. New South Wales has reached the 80% target, but this map here, which is from covid19data.com.au, shows us that the proportion of the whole population vaccinated is actually lower than that. So for New South Wales, it's 66%. For the ACT, it's almost 66%. For Victoria, it's 54.9%, Tasmania 56.5%, and all the other states and territories are below 50% of the whole population vaccinated, which means there's still substantial numbers of people who are susceptible to outbreaks. There are currently 353 active cases of COVID across 71 aged care facilities in New South Wales, Victoria and the ACT. And this actually highlights the issue of waning immunity from the vaccines. Many aged care residents were vaccinated in March during the phase 1A rollout, And there's now quite substantial data from multiple countries that are all showing the same thing, which is that vaccine rates vaccine protection, even against hospitalisation and death, does wane over time, particularly after the 6-month mark. So I think the question about boosters for frail elderly people who live in institutions and anyone else, including healthcare workers who was vaccinated early in the year, is really quite an urgent question. Next slide. This is the doubling time update provided by our colleague, Professor Rick Nunes-Vaz from Flinders University. And you can see that it's looking good in New South Wales, the ACT and Victoria, in the sense that we want to see those doubling times increasing. ACT is, you'd want to see it increase more than that. You know, it's kind of a bit flat in ACT. New South Wales is clearly looking good with numbers continuing to drop. And Victoria is going in the right direction. Next slide. In terms of hospitalisations and deaths, there's the table there on the bottom right-hand side, which breaks it down by state. And you can see that there's 137 people in ICU in New South Wales and 151 in Victoria, and 619 hospitalised in New South Wales, 777 in Victoria. There have been 95 deaths reported in the past week. 5 of those were linked to aged care outbreaks. Victoria is not reporting on deaths at home, and we'd like to see Victoria start to give us more detailed breakdowns of what's happening in that state. No state has reported deaths at home this week. There was 1 death in a 15-year-old. We have started analysing case fatality rate over time, and you can see the graph at the bottom left there. The black line at the top is New South Wales, and the grey line at the bottom is Victoria. And it's the change in the case fatality rate, which is the number of deaths divided by the number of cases. So it's the death per case ratio. And you can see that it's certainly increased in New South Wales. Maybe it's increased a bit in Victoria. We don't know what that means, but we think it's really important to keep monitoring this, because it could reflect lack of access to health services as health systems become overwhelmed. We've heard about ambulance ramping and difficulty getting ambulances, and hospital and the home system having some challenges as well. So I think this is something we need to keep an eye on. And that's it for the update. Thank you.
Thank you very much, Rena. And now what we'll do is we'll move over to a presentation from Professor Anne Kavanagh. Anne, if you could come on now. Thank you.
Thank you. Before I start, I'd just like to acknowledge that I'm on the lands of the Wurundjeri people of the Kulin Nation here in Melbourne, lands that have never been ceded. And I think it's important to note Lisa's introduction was very telling, but also I think it's important that we also note that the First Nation, Australia's First Nations people have very high rates of disability. So we are talking about intersections of disadvantage, both disability and indigeneity, which together put Indigenous disabled Australians at extreme risk in this pandemic. I just thought, if you want to put my slides up, I thought I would start though with a quote from my friend and colleague, which I've now, Dr. George Talaperis, who worked on this advice document with us, and he says, as a person with a severe physical disability who's likely to die if I catch COVID, I need the government to take action to keep people with disabilities safe. Our vaccination rate should be ahead of the population, but a lack of action has led to unacceptably low vaccination rates amongst disabled people and support workers. This needs to change. We can and must do better. We need the health system to respond to the complex healthcare needs of people with disabilities so that we can survive the pandemic and stop living in fear for our lives. So I really think it is a matter of life and death that we're talking about. And in terms of, I'm not presenting numbers today, but if you look on the government website, you can see increasing numbers of infections among NDIS participants, more than at any stage during the pandemic. There are well over 600 active cases in the disability sector at the moment, and an increasing number of deaths being reported. There is little transparency, though, in talking about what's actually happening there. But we need to look at international evidence here about what's happened to people with COVID-19 for people with disabilities. And in England, where there's much better data than Australia, we know that 60% of all deaths last year occurred among people with disabilities, who were 2 to 3 times more likely to die. There's incredibly high infection rates amongst people with intellectual disability, particularly those working and living in congregate settings, such as group homes or potentially institutions. There's 3 to 5 times the risk of serious COVID disease and hospitalisations among adults with intellectual disability, 36 times for people with Down syndrome. And for children with disabilities less than 16 years of age, they are 6 to 9 times more likely to be hospitalised for COVID-19. That's recent data out of the UK. Also, early evidence suggesting that after vaccination, for some people with disabilities, and this is emerging evidence, there are still much higher rates of death, 13 times for people with Down syndrome. Yet they're not included at the moment in the government's priority group for third vaccinations. And there's also evidence coming out of the UK at the moment that people with intellectual disability have deprioritised for life-saving care, even those without conditions associated with their intellectual disability. They're being deprioritised and discriminated against in accessing life-saving care like ICU and ventilation. Next slide, please. I just wanted to remind you of the COVID-19 roadmap. People with disabilities living in residential settings and staff were included in phase 1A of the rollout, and adults with disabilities, sorry, the red marker's gone off the slide, were also included in phase 1B. Let's compare what's happened to the people living in disability group homes. We have about 74% of those folk fully vaccinated, compared to a large proportion, this is as of the 12th of October, of aged care residents as appropriate who should be vaccinated, but were in the same priority group. And we are seeing outbreaks in group homes at the moment among unvaccinated people with disabilities. We see a vaccination level for NDIS participants, remembering that NDIS participants make up 10% of all disabled people in Australia, and they're people with severe permanent disability. Their rates are still lagging the general population rates of about 8% for 1 dose and 6% for full vaccination. And that varies very much across the country, but is consistent. They're consistently lower in all states. And there are some areas where they are extremely low. And compared to all adults over 70 years of age, you can see also prioritised in 1B, NDIS participants that have received 1 dose is 76% compared to over 95% of Australians in the 70+ population. So still being left behind. Next slide, please. So just to touch on why people with disabilities are at risk, and what we've tried to do in this advice document is provide recommendations that kind of address all these risk factors, if you like, to some extent. So first of all, individual risk factors, medical conditions, increased exposure to COVID-19, either through support workers, family members needing to be supported by people providing very basic and potentially intimate care, like feeding, self-care activities. Extreme disadvantage, much higher levels of disadvantage, poverty, crowded housing, and systemic factors that have been endemic and not fixed before COVID, and which are showing the cracks now, which is access to quality health care and lack of coordination between the health and disability service systems. So in our document, we've made 9 recommendations to reduce the risk for people with disability during COVID-19. Next slide, please. The first, and I think a pretty obvious one, which has not happened as it should have, is to co-design prevention and control strategies through community partnerships with people with disability, with people with disabilities representative organisations, with disability services, families and carers. And that must happen urgently, because at the moment we aren't reaching a sizable proportion of this population. We need, as Lisa pointed out with Indigenous Australians, we need improved data quality and reporting, and we need transparency. It's not being reported in a visible way to the entire, to the public, and bits get released through media releases and so forth, but there's no publicly available data. It's not reported by LGA, and it makes it very difficult to plan strategies. We also don't know whether rates are different among different groups of people with disability. Like with Indigenous Australians, we'd like to see much higher vaccination targets, well over 90%, potentially 100%. And we know some service providers have pretty much vaccinated 99% of their NDIS participants living in group homes, but we see much lower rates among other disability service providers. All staff working with people with disabilities, and including support workers and allied health professionals, need to be fully vaccinated, and in some states that's now a recommendation. And again, a rapid escalation in vaccination needs to happen. People are very frightened in New South Wales and Victoria as we open up, and unprotected still in fairly, with a lot of risk to them of increasing contact between people. So next slide, please. I think one thing I wanted to point out there is the effectiveness of vaccination really needs to be reinforced. A lot of people in the disability sector have heard stories about vaccinations, particularly in relation to autism. We need to counter some of those narratives very strongly. And then, as OzSAGE has said many times, there need to be strategies to reduce transmission of SARS-CoV-2. So that relates to safe indoor ventilation, making sure that that there is ventilation within congregate living environments, for instance, and we've put out a number of recommendations regarding that. Ongoing mask use, rapid antigen testing, for example, again, following OzSAGE's previous advice on creating safe workplaces. On paid leave for workers who are suspected or known to have COVID-19. This is really important. This is a highly casualised workforce. 50% of the workforce is casually employed with no sick leave, no paid leave, and often poorly employed. And they they should not have to make the decision about whether to lose a wage by taking sick leave versus going to work sick. This is also a workforce that needs to have ongoing infection control training. It's also a highly mobile workforce. So we've made some recommendations in relation to limiting ongoing limitations on worker movement. There needs, bizarrely, the outbreak management guidelines for disability residential care settings have not been updated to recognise airborne transmission. And a lot of the services are currently already doing their own contact tracing, but need some support to do that properly. as Raina pointed out, we need to prioritise thinking about third vaccination doses for people with disabilities, both because of underlying risk due to some immunocompromise, but also because of their increased exposure and vulnerabilities to infection, and some have been vaccinated more than 6 months ago. There needs to be better support for people with disabilities who acquire COVID-19 infection in the home and in hospital. One of the concerns that many people with disabilities report is that once they go to hospital or in the home, they start to lose some of their essential supports, which are actually really important for very basic things like eating and bathing and so forth. And so there needs to be made sure that that is carefully coordinated if people become COVID positive. And finally, we want to ensure that people with disabilities are not deprioritised in their access to care. Often people make assumptions that having a disability necessarily means you have poor health, or that your quality of life is poorer because you have a disability, and that your what we refer to here in ethical terms as social utility, your so-called usefulness to society is less because you have a disability, which all of these things lead to deprioritisation of people with disabilities in access to care. And we have seen that in the UK. And sometimes these assumptions are implicit. So we must make sure that all triage guidelines do explicitly state that people should not be deprioritised for care on the basis of disability alone. And finally, this video will be made available afterwards with with captions as well. Thank you.
Thank you very much, Anne. And just a reminder of that point about what we've seen today is about intersections of disadvantage. I'll just check now to see if we've got any questions coming from those in the room. What we've done now is we've finished our 3 presentations and just waiting now for some questions. No questions to date. So what I will also do is just remind everybody that the advice documents will be available on the website, which is www.ozsage.org. You can also contact Amy Stevenson on 0432 806 703, and Amy will be looking after media inquiries today, and her email address is amy.stevenson, STEVENSON @sydney.edu.au. So if we have no questions coming from, I was going to say from the floor, but from the room, we'll just say a big thank you for your interest today, and thank you to all of our presenters, and a reminder again that the documents are available on our website. Thank you. Look forward to seeing you again.